Case 1 is an 81-year-old gentleman who had a routine chest radiograph following a valve replacement. On physical examination, we can hear that there is decreased breath sounds on the right. There is a systolic ejection murmur, or a systolic ejection click, which is best heard at the second intercostal space and the right sternal border. Laboratory investigations were not contributory. Here are the chest radiographs, which I will review in a second. But before I do so, I'd like to go through a brief approach to chest radiograph. On the frontal view, you want to look at ABCDE, which involves looking at the airways, including assessment of the trachea, the carina, the bronchi, and hilar structures. For B, you want to look at the lungs and pleural space. For C, you want to look at the heart size, the cardiomediastinal silhouette. For D, you want to look at the diaphragm, as well as assessment of the causal phrenic angles. And you want to look for everything else, which include the mediastinal contours, bones, soft tissues, tubes, etc. Here's how I approach the lateral view. There are 5 things that I look for. First, I look at the retrosternal space, which is the space behind the sternum, as well as the retrotracheal triangle, which is this triangle behind the trachea. And both of these spaces should be clear and loosened. There should be no discrete mass at the hilum, and the major fissure, outlined by this black line, and the minor fissure, this white line, should both be pencil point thin. As we move down the posterior spine, this should become more loosened as we move inferiorly. If this becomes more white or opacified, then that can be a sign of consolidation. And the right hemidiaphragm should be located superior to the left hemidiaphragm, and both causal phrenic angles should be sharp. If there's plenty of the causal phrenic angles on the lateral view, that can be a sign of pleural fluid, as the lateral view is more sensitive for the presence of pleural fluid compared to the frontal view. So back to our case, this is a posterior anterior radiograph as well as a lateral radiograph of the same patient. And we can see that there is this vague opacity on a frontal radiograph in the right hemithorax. And on the lateral radiograph, this opacity becomes this elongated lenticular-shaped opacity that's expanding the major fissure. And we can see that there is also blunting of the causal phrenic angle. So what this is something called pulmonary pseudotumor. It's often caused by pleural fluid, and especially by a loculated effusion trapped within the pleural fissure. It's important to have a knowledge of the major and minor fissures, as they can often appear elongated along the fissure with tapering ends, like the case in our case. And obtaining a lateral view is often very helpful. Now I just want to have a brief discussion about valve replacement. So there are 4 valves within the heart: the aortic, pulmonic, mitral, and tricuspid valve. The easiest way to identify these valves is by drawing an imaginary line between the apex of heart to the base of the heart. Above this line is the aortic valve and pulmonic valve. The aortic valve sits just above this line with the valve almost touching the line, and the pulmonic valve is more superior. Below this line is the tricuspid and mitral valve, with the tricuspid valve located more anteriorly compared to the mitral valve. So in our case, if we were to draw this imaginary line, we can see this valve sits just above the imaginary line with the valve touching the line. So this is case of aortic valve replacement. This is case number 1, a case of pulmonary pseudotumor caused by a pleural fluid with a prosthetic aortic valve.